Welcome from CVI2017. I'm Dr. Michael Luna, here with Dr. Sara Martinez from Providence Cardiology Associates, St. Peter Hospital in Olympia, Washington. She'll be talking about axillary impella-assisted left main and LAD PCI.
Great. Thank you to the organizers for being here. I'd like to talk about a complex case I had early in my career. It's an axillary impella-assisted left main and LAD PCI. So the patient is a 66-year-old gentleman, known coronary artery disease, RCA-CTO since 2006, severe peripheral vascular disease with bilaterally occluded external iliac arteries. He also has a right radial artery occlusion. He also has right subclavian, right innominate brachiocephalic stenosis, severe COPD, hypertension. His LVEF was 60% in June 2016. He presented in late October with pneumonia, 20-pound weight gain, and a new oxygen requirement. He had been somewhat absent of the medical system. His creatinine was 1.8 and elevated from his baseline of 0.7. He had a slight troponin elevation of 0.5 and therefore had a transthoracic echocardiogram. And shown is the echo from his pneumonia presentation and 20-pound weight gain. Obviously, we see LV dysfunction, severe systolic dysfunction, EF estimated around 15 to 20%. He had a very complicated hospitalization. He decompensated quickly. His creatinine increased to 3.5. I was the consulting physician. I began aggressive dobutamine and furosemide drips, got his creatinine down to 1.4 with diuresis and the dobutamine. He was very reluctant for a procedure, as he had been in the past, and palliative care was obtained as a consult from the hospitalist. The way we left it was to allow him to spend his possibly last Thanksgiving at home with his 2 adult daughters and their families, and then we would reevaluate the situation. The patient reconsidered possible intervention, and we scheduled an elective diagnostic angiography. And then his platelets had decreased and sent out for a HIT antibody test, and it returned positive with borderline confirmatory testing. So in 2007, the patient had an angiogram performed which demonstrated his RCA-CTO and some mild to moderate disease in the LAD, and the patient declined treatment. He was feeling somewhat okay. However, in November 2016, I performed the angiogram via the left radial artery. That was a difficult diagnostic catheter to get through the forearm. He had significant dampening with a 5 French catheter. His blood pressure was so low in the 70s. This was one of those situations where you just take 3 shots and get out. Yeah. He also had severe peripheral vascular disease. I'm not sure if it can show quite well, but his brachiocephalic has some significant stenosis, and prior lower extremity angiogram performed 10 years ago showed that he had bilateral occlusions of the external iliacs, and this was confirmed again with ultrasound testing. So we had to devise a plan for this gentleman as he was rapidly decompensating. The plan for this gentleman then was number 1, hospice or palliative care, and number 2, attempt at revascularization. At this point, the patient just wanted to give it everything he had to survive. So my plan was for general anesthesia, percutaneous right axillary impella CP placement, left brachial access in order to get a supportive guide, bivalirudin for the procedure, and a plan for osteal left main, PTCA and drug-eluting stent placement, and possible mid-LAD PTCA drug-eluting stent placement depending on how the patient was doing. Obvious deferral of RCA-CTO work at this time. Patient's creatinine was at 2.3, and on the day of the procedure, the patient looked terrible. He was hypotensive, dyspneic, sitting upright, and after general anesthesia induction, he became mottled. And I told the family that the procedural mortality risk would likely be very elevated, 30 to 40%. With the assistance of our vascular surgeon, Tom Curry, we got the percutaneous right axillary artery sheath placement. And then we also inflated a balloon just to make sure that we would be able to advance the sheath comfortably. The impella was placed without complication into the dilated left ventricle. Using the EBU guide 7 French, was able to perform PTCA with a 3012 with the left main. I should note that every time we did a PTCA, any balloon inflation at all, his pressure would essentially flatline, and he became 100% dependent on the Impella support. My strategy was then to stent the left main, and I used a 4x12 Synergy stent in the left main. And then once that looked okay and he was doing better and would give him time to rest and recover after balloon inflations, I decided to proceed with drug-eluting stent placement to the mid-LAD. As you can see from the right-hand video, the patient had markedly improved flow into the left and right systems. So the decision was then to terminate the procedure for PTCA, PCI, leave the Impella in place to help with the cardiogenic shock. This is classified as a salvage PCI. So he transferred to the CCU with bivalirudin, therapeutic ACT levels, and the Impella CP was in place. He was also on norepi and dobutamine for assist with support. However, overnight, the patient had a massive GI bleed, melena, bright red blood per rectum, so we were managing simultaneous hemorrhagic and cardiogenic shock. Stopped his bivalirudin. I continued the Impella for 24 hours. Had used the peel-away sheath instead of the long sheath, and my concern was not for the Impella clotting, but for thrombus around the sheath. The axillary, this is different. So we left the sheath in place, left everything in place. The bivalve was stopped. And then subsequent scans found the patient to have significant small bowel AVMs. He also had large bowel AVM as well. He then developed DVTs for his hospitalization, aspiration pneumonia. However, he did get discharged to an inpatient rehab facility. So he did well for many months, but has since elected to go on hospice because of worsening dyspnea, and he would rather just not think about his heart for the moment. So I'd like to just give some acknowledgments. I'd like to acknowledge the staff at the hospital and additional interventional cardiologists who I discussed the case with at length, Thomas Curry of Vascular Surgery. I'd like to thank my training at Mayo Clinic and the CV Innovations course. Thank you. Great.
It's a fabulous case. Very complex and high risk indeed, especially in patients who are presenting with decompensated clinical heart failure to that degree. Any consideration for more support up front in a patient like this, more than just the Impella CP?
Well, his RV had mild to moderate dysfunction. Additional support, I think, would have increased afterload reduction. We also had issues of access. So this is a patient with no lower extremity arterial access. I think the best thing we could have done was, I think the Impella CP, due to the relatively small caliber sheath of 14 French, would have been fine for him. And additionally, we did consider the Impella 5.0, but this gentleman probably hadn't seen a cardiac output of 3 liters a minute in months.
Right.
So our thinking was that we would get the CP to tide him over, and that the perfusion of the myocardium, which was demonstrated to be viable, would rally. Yeah. So that's what I thought. The CP, we went to minimize vascular trauma, also the subclavian stenosis, and the sheath left there, and then that was repaired surgically. That was just even though it was percutaneous, the vascular surgeon took him to the OR and just 10 minutes, 15 minutes, sutured it up. Right.
Yeah. What we've gone to do at our center is have the surgeons create a chimney graft and implant the 5.0 so that the majority of the sheath sits in there and reduce your risk of vascular injury and all those things. And so would have been a good consideration here for sure. Did his left ventricular systolic function improve at all after this? Okay.
His EF went from 15% to about 33%. And he was living with his daughter begrudgingly because she had him on a diet and exercise regimen, and things had improved, but then he just wanted to live at home and do what he wants. So at least we bought him 7-8 months to spend with his family at least.
Absolutely. Great case. Thank you so much.
Thank you.
All right.
Thank you.